Alpha-1 antitrypsin deficiency, abbreviated AATD, is a hereditary disorder in which there is a deficiency of the enzyme alpha-1 antitrypsin. This can lead to tissue damage in the lungs and liver. When diagnosed as early as possible and managed continuously, patients are able to enjoy good quality of life in the long term.
Alpha-1 antitrypsin deficiency is a rare but potentially severe disease that can affect people of any ages, from newborns to adults. Severity is variable in both liver and lung disease, from asymptomatic forms to severe damage that may require a liver or lung transplantation. That's why it is important to make the diagnosis early, in order to identify severe patients and refer them to an experienced center.
The prevalence of severe forms of AATD is about 1 in 2,500 individuals. Often, the disease remains undiagnosed because it is asymptomatic for a long time. Liver injury already occurs during childhood, whereas pulmonary symptoms usually appear later, after the age of 30. Males and females are equally affected.
Alpha-1 antitrypsin deficiency results from a genetic disorder in the alpha-1 antitrypsin gene, leading to a misfolded alpha-1 antitrypsin protein that polymerizes in hepatocytes and leads to a proteic stress responsible for liver damage. This represents a gain of toxicity. The alpha-1 antitrypsin is therefore deficient in the blood circulation and cannot act in the lungs to protect them from leukocyte elastase, leading to a loss of function responsible for emphysema and destruction of lung tissue.
Deficiency of the protease inhibitor alpha-1 antitrypsin is inherited in an autosomal recessive manner. The gene SERPINA1 on the long arm of chromosome 14 is encoding for AAT. In homozygous state, a mutation of this gene leads to deficiency of circulating AAT and a severe form of deficiency syndrome. In a heterozygous state, the deficiency is less severe and leads to moderate or asymptomatic disease. When AATD is diagnosed, the entire family should be screened to detect unknown AAT deficiencies.
The severity of the disease is variable and may be conditioned by the presence of cofactors. Alcohol consumption, obesity, or other liver disorders can aggravate the liver disease, whereas smoking promotes the earlier onset of lung emphysema.
Liver involvement of AATD presents as hepatitis at birth in 10% of cases. This may resolve spontaneously or develop into chronic liver damage. In others, the liver inflammation is revealed later in childhood or in adulthood. Sometimes it may progress to cirrhosis and portal hypertension. In the lungs, the deficiency of alpha-1 antitrypsin from the age of 40 onwards leads to the development of emphysema and atypical early chronic obstructive pulmonary disease. In smokers, lung disease may develop earlier.
Other rare manifestations of alpha-1 antitrypsin deficiency have been described, such as panniculitis, for example, corresponding to painful subcutaneous nodules.
The symptoms of AATD correspond to the organ systems affected, especially the liver and the lungs. In newborns, signs of cholestasis are jaundice, pale stools, and an elevation of conjugated bilirubin in serum. Older children are usually asymptomatic, with occasional asthenia and abdominal pain indicating AATD. Pulmonary symptoms include increasing dyspnea and cough. Emphysema may result in visible thoracic distension.
Any newborns who present a jaundice for more than 2 weeks must have a bilirubin dosage in order to identify neonatal cholestasis, which must be explored in a specialized center to exclude the diagnosis of biliary atresia. This excluded, other rare liver diseases should be investigated, including alpha-1 antitrypsin deficiency. Otherwise, AATD should be considered in any patient, child or adult, who has a chronic disturbance of liver biology, such as elevated levels of transaminase or gamma-GT. When alpha-1 antitrypsin deficiency is suspected, measurement of AAT level in serum should be performed, and if it's below 1.1 grams per liter, it should be completed by phenotyping and/or genotyping. Then, liver biology and fibrosis should be assessed. Liver biopsy is rarely performed due to the availability of non-invasive tests of fibrosis. For adults only, pulmonary function tests and CT scans may specify the lung disease. The complications of alpha-1 antitrypsin deficiency are, for the liver, a cirrhosis with the usual complications such as portal hypertension that is responsible for splenomegaly, low blood count, especially in platelets, ascites, and digestive bleeding due to esophageal varices. Rarely, a hepatocellular carcinoma may occur. For the lungs, the destruction of parenchyma may lead to emphysema. To date, treatment of alpha-1 antitrypsin deficiency remains mainly preventive. Limiting alcohol consumption and fighting against obesity can delay the liver complications, and it is strongly recommended to avoid smoking to protect lungs. In some cases, especially if cholestasis, ursodeoxycholic acid may improve liver biology. Cirrhosis is managed as all causes of cirrhosis, with follow-up and preventive and curative treatment of esophageal varices, and usual management of ascites if present. The only treatment for end-stage liver disease remains liver transplantation, with very good outcome both in children and adults. Lung disease also requires specialist follow-up, and emphysema may be treated by AAT supplementation. In most severe cases, lung transplantation may be indicated. Some promising therapies are being studied, and clinical trials are currently underway. In case of questions about the management of a patient affected by alpha-1 antitrypsin deficiency, you can contact experienced centers within the European Reference Network for hepatological diseases.
The website of the European Reference Network, ERN Rare Liver, provides details of hospitals, disease-specific information for experts and patients, webinars for further education, and the Clinical Patient Management System, CPMS, allowing the option to discuss cases virtually with international experts. Only severe alpha-1 antitrypsin deficiency becomes a problem for patients. Because a specific therapy is not available, expert management of patients is crucial to maintain the best possible quality of life for as long as possible.
Alpha-1 antitrypsin deficiency, although a rare liver disease, remains underdiagnosed. The key in infants is to early identify a neonatal cholestasis that requires specific management. Later, it is important to think to alpha-1 antitrypsin deficiency to detect severe forms and to refer these patients to experienced center in order to guarantee optimal care, especially if a transplantation is to be considered. In the near future, there is a realistic hope of improving therapies that could replace the need for liver or lung transplantation and to improve the patient's quality of life.